is normal for me.
Yes, I get the impression that you are massively busy.
Yeah, it's one of those things, but we're good to go now. It's just been crazy busy the last few weeks, but so be it. We're good. You're doing a phenomenal job with all this uric acid stuff. Very impressive.
Well, thank you. I'm on a train now. Let me just say before we get started that we're live on YouTube and also LinkedIn, and
Right.
and I want to let anybody know who's watching right now that we have Dr. Cywes, bariatric surgeon, and also other weight loss procedures. He's an MD, PhD. He's known as the Carb Addiction Doc. On his YouTube channel is Dr. Cywes, Carb Addiction Doc, and I would recommend anyone who's thinking about if you're significantly overweight and you're trying to sort out how you want to go about losing that weight, you should check out his YouTube channel. There's massive amounts of content there. And I want to say on a personal note that Dr. Cywes was actually one of my teachers at the Nutrition Network. And he was the first one actually that raised the issue of carb addiction in trying to help people shift into the keto lifestyle to lose weight or reverse diabetes or to reverse cardiovascular disease. And at the time when I heard this, I was brand new to coaching and didn't really know what I thought. But as soon as I got started and took on my first clients, I realized that Dr. Cywes was really onto something. I mean, this is the challenge. And quite frankly, if you're interested in sustaining the keto lifestyle or sustaining a lifestyle that keeps you at the weight where you want to be, or in reversal of the diabetes, or also where my interest is at the time right now in gout remission, that you have to pay attention to these pressures, because if you don't, you end up back in the carbs and you're just going to undo all of the progress. But with that introduction, I really want to thank you for meeting with me, and I'm really, really excited about this conversation because I would really like to pick your brain about the issue of gout. I get the impression that you're actually treating people. And that's the other thing I want to say about Dr. Cywes is that besides his numerous credentials and qualifications, this guy has been, he has more experience maybe than anyone in the world with this, perhaps, or he's at least up there at the very top with doing this with people. So he's the guy that I'm really interested in because of this logistical thing, right? Taking the science and then making it apply to the health of the people that we work with. And I'm fortunate to be speaking with you today. And I'd like to pick your brain about gout.
Sure, and I think, along with that, we have to include not just gout, but the causative agent, which is uric acid, which is really there are other forms of joint inflammation, but when we're talking about gout, we're really talking about uric acid and the metabolism of uric acid in the human body. Is that reasonable to say?
Yes, absolutely. I'm sorry, I'm bouncing around a little bit. We're going to have a guest. His name is Scott, and I'm going to be super respectful with your time, Dr. Cywes. So when we get about 50 minutes into this, I'll make a prompt, and then Scott's going to have a question or two for you. Let me
interrupt you for a second. This is a subject that's very important to me and my patients, and it's one that I'm certainly not an expert on biochemically. So I'm here to learn as well as to share some of our clinical experience. So we'll talk until my knowledge is good. I'm a surgeon. I'm a very slow learner. So hopefully we can flesh this out and have more of a discussion than anything else, if that makes sense.
So the reason I got interested in this is because I'm a gout sufferer. And, I've been in a process over the last 3 years. I also was pre-diabetic, right? And back when all this started, the thing that was at the forefront of my mind was the pre-diabetes. I'm like, I need to take care of this, right? And I saw the gout as more of a nuisance thing. I didn't understand that there was
Can I
actually,
stop you for 1 second?
yeah,
Every human being is pre-diabetic. I hate that term. It's called insulin resistance. And
right.
it's such an important change in thinking because most people think they're pre-diabetic. Ha ha ha, I'm fine. I just got to be careful. That's not true. And because a large contributor to your gout is because you had insulin resistance. So
Exactly.
it's just, I know I'll talk about things, but it's so important that we get our terminology correct. Ben Bickman is another guy that's a big fan of correct terminology because it carries an inappropriate message. And
Right.
61% of kids that are 5 years old have insulin resistance now. So I think that's a very important component. And we're going to explore the components that involve gout and insulin resistance, if it's okay just to change that terminology.
Oh, no, I don't have, yeah, I'm fine with that. So let's just cut to the chase then. When I was going after the gout thing and learning and educating myself about it, I discovered there were two things. I discovered that people walking around with hyperuricemia can be completely free of gout, and there's a significant number of them. And I also found out that when you aspirate the joints of those individuals, the ones that are free of the gout but hyperuricemic, that you can find crystals there. So the lesson right there for me was that, all right, crystals aren't enough. When you have a gout flare, there has to be other things going on. That was lesson number one. And lesson number two, once I was established in the ketogenic diet, I started measuring my uric acid because of what I understood about the fact that people will have a spike in uric acid when they first go onto the ketogenic diet. And I've been measuring my uric acid with a handheld meter now for 3 years. And I knew that there were times when my uric acid in the beginning of this process was really high. I mean, I've had some values that were at 12 mg per deciliter, but I did not have a gout flare. So those two pieces of information, the fact that you have people that are hyperuricemic with no gout flare, and the fact that in myself, I should have been a walking, talking gout crystal at that point. And then I came across Richard Johnson's work, the fructose uric acid model of diabetes, obesity, and cardiovascular disease, and I got immersed in his papers and also the writings of Lustig. And I realized right away with Johnson's work that there was potentially an explanation for the gout because of the sudden acute rise issue that you have when someone ingests either alcohol or fructose or those two things together. And this is one of the things I wanted to talk to you about. The issue of protein obviously has to be considered. And then there is also the issue of exercise. In any case, to make a long story short, and I can open this back to you, is that I took all the information, all of the needles in the haystacks that were connected that I could find in Johnson's work, and I started looking for the presence of whether or not the chondrocytes that are in the joint or the innate immune system could produce that inflammatory cascade, whether or not those cells could produce uric acid intracellularly, whether or not they could produce the cascade, and whether or not they could generate the NLRP3 inflammasome right on site. And I was able to track all of that in the literature and find at least literature evidence for it. And so that's where my hypothesis, I don't want to call it mine, really it's an extension of Richard Johnson's work is what it is, that gives us a handle on perhaps how the gout flare is actually happening.
Right now, I think that there are so many aspects of this to break down and discuss. The first concept is that gout specifically is usually an acute symptomatic condition. In other words, it's a symptom that the patients feel. So
Right.
it has to involve inflammation, and the crystals trigger, as far as we know, a high concentration of triggers in the joints, together with probably something else, triggers an acute inflammatory response within the joint capsule. and the inside of the joint capsule is acellular. It's a fluid matrix. You can put a needle in there and aspirate usually a clear fluid from that. So if ever you've twisted a knee or twisted a joint, the fluid that accumulates, that's the joint fluid that can accumulate there. So gout is a clinical condition that is reported by patients, and the doctor then makes the diagnosis, ideally by sticking a needle into the joint, aspirating the crystals, and confirming that the uric acid crystals are high in the joint. So that's the first most important thing. However, other places where uric acid can also cause similar problems. So you may have it in your joint at either a subclinical or a tolerable level where your joints hurt. You say, oh, I'm getting old, I've got some arthritis, or, I had a rough night last night drinking, I've had a big bender, and now I've got my joints are inflamed. People will explain that by other things because it is a clinical symptom. However, once you've had it and it's ugly and you understand what it is, when it flares up again, you're more likely to say, okay, I've got a gout flare again. The uric acid crystals can damage multiple areas in the human body. The two most common are the joints, and the second place is they are the second commonest cause of stones in the kidney. So uric acid is most commonly excreted in the kidney, and in humans at least, and we've got to isolate humans in this regard, but uric acid can be concentrated in the kidney either because of kidney damage or because of hyperuricemia, where there's an increased concentration of uric acid in the urine and it crystallizes out. And the simple way to understand this is if you take some seawater or some salt water and you dehydrate it slightly, there's crystallization of that salt. Salt is a crystal. And in exactly the same way, uric acid or urate is a crystal that occurs because it's saturated in the space in which it is. So the first place we see it is in the joints. The second place we see it is in the kidneys. But we also see uric acid crystals in the skin, and it can cause itching and inflammation. And then finally, we can see it in the small blood vessels or the capillaries. That's an English word. Americans say it differently, but the very tiny little blood vessels of every vascularized organ, you can get inflammation caused by uric acid crystals occurring in fine capillaries. And that's important when we talk about diabetes and insulin resistance in a little bit. The final bizarre thing about uric acid is that it is probably if not the second most powerful vascular antioxidant, protective mechanism, second probably to vitamin C, or certainly competing with vitamin C as an antioxidant. So uric acid has an important positive role in the human body, but we're not talking about uric acid specifically. We're specifically talking about excessive uric acid. And by excess, it's not necessarily a measurable number, as you said. It is an excess for that particular patient. And that also brings to the table a genetic component that there are some people, because gout does run in families, there are people that are more susceptible to gout than others just by family. In other words, they get the disease at a lower uric acid threshold. So those are the clinical scenarios. The second part that is very poorly recognized, it's almost like someone with a stroke, because any doctor you ask about uric acid and where does it come from, they'll immediately tell you it's the breakdown of purines and pyrimidines from cellular breakdown. Right. Either you've eaten the cells or you've eaten a lot of meat or shellfish, that kind of thing, or you're going through your own breakdown of your body, whether you're losing weight very rapidly, whether you're going through cancer and losing weight. So the primary role that people ascribe to gout is the purines and pyrimidines, and that's the functional arm. Yes, it occurs from those. The part, when I say a stroke patients kind of ignore their bad arm. The part that's been completely ignored by physicians is the role of fructose in uric acid crystallization. And fructose is by far more commonly consumed in this country now than any of the animal products or the red wines or the other things that have traditionally been the gout of the rich and famous from centuries ago. So the primary trigger, I would tell you, is not the meat that we eat or the shellfish that we eat or the red wine that we drink. It's almost certainly, and I don't have corroborative proof of this, it's almost certainly, in my opinion, an association on top of fructose with maybe one other component coming in, which is called hypoxia, or a lack of adequate oxygen in the bloodstream. So we've got a combination of fructose, the purine pyrimidine breakdown products, and hypoxia that is the setup for pathologic uric acid disease. Does that make sense?
Yes, and I totally agree with that. And when I listen, you're putting out a lot, right? So let me try to distill some of it, or the way I think about it. So the thing that got me going with this was number one, Johnson's core work that indicates that when you have fructose, you generate this sudden acute rise in uric acid, and then that is directly stimulating this inflammation pathway where this protein junk 1 is at the pinnacle or at the top of that. And then when you think about how Lustig writes about this, you have an organ system. If you take the kidney, for example, or you look at the liver, where during a particular kind of meal, you don't have just one culprit showing up there. You don't have just the fructose, right? You perhaps have a bolus of alcohol. You also have the glucose, and all of those guys are arriving at the same time. And we know that the glucose can be converted into fructose by polyol, right? So I agree with what you're saying, but when you talk about the kidneys, the way I thought about it was I went, all right, which part of the kidney is metabolizing fructose? And I still don't have the answer in regard to alcohol, but I know the proximal tubule metabolizes fructose. So, and I think that polyol pathway would be functional there. And I know that in the cartilage, for example, the chondrocyte is a specialist in glycolysis. And I know that the synovial fluid, the concentration of glucose there and fructose is going to reflect what the serum concentrations are. They're not going to be exact, but it's going to be reflective. And I know the chondrocyte also can take in fructose there in addition to the glucose, and you have a hypoxic environment. So the chondrocyte itself is capable of generating the fructose endogenously, also bringing it in, so you have a way of generating the intracellular uric acid. You have a way of activating that inflammatory cascade. And then you've got the immune system sitting there, the innate immune system. And those cells, those resident cells, the neutrophils, I think they are, and I can't remember the other two off the top of my head. I tracked what their abilities are, right, and how what they can be responsive to, and all of them are capable of metabolizing glucose and fructose. And again, polyol. So you have maybe this cluster. You potentially have a perfect storm there, because you're going to have uric. Oh, and the chondrocyte can also transport uric acid out. Right? You have the GLUT9, and you also have the URAT1 receptors that can pump uric acid right into the synovial fluid. So you have the crystals potentially. You have NLRP3 because of the initiation with junk1, and possibly IL-1 beta. So, and whether or not the innate immune system's talking to the chondrocyte or the chondrocyte's talking to the immune system, I'm not sure which there, right? And I'm not sure, though, that it has to be one way or the other. And under the right conditions, and I don't think that these are the only things that are involved in this, then you can get the gout flare. What scares me about what you're talking about, well, I have questions about the kidney. For one, like the kidney damage that could potentially be happening there. But these other things you're talking about are equally scary. The stuff in the small blood vessels and things like that.
Let's circle back to insulin resistance as well, because one of the key things about fructose is that it enters cells independent of insulin. It can use an insulin pathway, but it also enters cells without triggering an insulin response. So fructose is your most dangerous carbohydrate when consumed in excess. And fructose, I think that the liver responsiveness is probably more important in terms of
Yeah.
uric acid generation. The question always is the uric acid, is the kidney and the joint an innocent bystander to supersaturated fluid, or is it an active process of uric acid formation and excretion? We know the kidney excretes it, but is this a byproduct of an excretory byproduct, like the gallbladder is the innocent concentrator of cholesterol in the gallbladder and then forms stones in a supersaturated bile? It's not an active former of cholesterol stones. It just happens to be collecting there. Well, certainly the kidney is a collecting system for uric acid. That's where the majority of it in humans is excreted. So I suspect that the liver is integrally involved in this process in terms of the generation of the uric acid, more so than anything else. And the crystallization is perhaps a secondary component or an innocent component in the kidney, more so than an active process. Now, the other thing about insulin resistance, and especially as you head toward true diabetes, as your A1C starts going up, insulin resistance damages the kidney as well at a subclinical and a clinical level, and specifically damages the blood vessels in the kidney as well. So you've got this perfect storm happening. But I think that the focus has to be on people that consume sugar in a chronic, excessive way. And
Yes.
when we say fructose, people may say, well, I don't eat a lot of fructose. Well, sucrose is one molecule of glucose and one molecule of fructose. So sucrose, by definition, anything with sugar in it, by definition, is a combination of the two. Glucose alone does not occur very commonly as a glucose-glucose combination. And so it's very rare that we see glucose in our diet. It's usually glucose fructose and sometimes glucose galactose. So fructose is a very, very important molecule and consumed in excess. And as we start to get that insulin resistance, those numbers, those fructose and glucose numbers, increase in the peripheral bloodstream. In a normal, healthy person who does not have prediabetes, what we call the first pass effect, the liver sucking up all the fructose out of the gut and converting it either to glycogen or to glucose, is extremely high. But under conditions of high fructose consumption, you can bypass the liver and more of that gets into the systemic circulation. So the question is whether that fructose is really active at the liver level or beyond the liver. That's the first thing. The only other thing I want to throw out there is that, and this is such an important point, and the reason why I'm focusing on fructose, not the purines and the pyrimidines. And as you said earlier on, we see hyperuricemia, high uric acid, hyperuricemia. Sorry, my technology, hyperuricemia, and yet it doesn't always equate, as far as we know, with kidney stones and gout. And there's a particular population where we see this at a very, very high rate. And I've got measurables on that, and that is in our carnivore veteran group. The carnivore veteran group, especially the nose to tail or the high seafood consuming ones, consume extraordinary amounts of purines and pyrimidines, but they consume almost no fructose. And while we've measured in our own patient population an average uric acid level of 7.8, which is very compatible on the standard American diet with gout, these patients hardly ever, if ever, get gout. And the reason for that is because they don't have the prediabetes. In fact, they have super low levels of insulin, super low A1Cs, and very, very low blood sugar levels. So they do not have the diabetic predisposers to that saturated uric acid. So I think it's a combination of the purine pyrimidines as well as the fructose that initiates that clinically inflammatory response. Because we know uric acid is an antioxidant, but we also know that elevated levels of sugar are a very, very powerful intravascular pro-inflammatory molecule. In fact, in my PhD, I used high levels of glucose, fructose, and galactose that we infused into animals and into humans to create the inflammatory response we were looking at. And with statistical significance, the molecule that had the highest inflammatory response in my research, and remember, I was using it as my model to create intravascular inflammation, was fructose. And that was independent of and uncontrolled by glucose. By insulin. Insulin could control glucose, but it could not control fructose levels. So, we infused fructose into people to create a vascular injury. And we're talking about vascular injury in the kidney and quite possibly in some of the joints. And you combine that with hypoxia, you're getting a triple hit.
What I don't understand the part about okay, I think about hypoxia in terms of the polyol pathway. So when you combine it with hypoxia, what do you mean exactly?
So for example, if someone has done some athletic work or they've gone to altitude, right, there's a much higher, when the partial pressure of oxygen in the bloodstream is slightly lower and can only be a few points. A lot of people have oxygen saturation monitors now in COVID. So for example, when people get COVID, we see uric acid levels go up. Those are the inflammatory responses that we see under hypoxic conditions. And hypoxia is closely associated, and it may be the xanthine oxidase pathway that gets affected by hypoxia. I'm not a biochemist. I defer to the biochemists, but I believe it's the uric acid cycle that is affected by a lack of adequate oxygenation.
All right, I'm writing that down. I'm going to have to chase that down. All right. How do you know when you've reversed prediabetes?
You can measure it. It's very measurable. We measure insulin and C-peptide levels all the time in our patients. And that's by far the most common. Not many doctors do it, but it's the easiest way to check whether someone has reversed insulin resistance. When low levels of insulin combined with a low blood sugar are effective. So if you look at a type 1 diabetic, they have very low insulin levels, but very high blood sugar levels if they're untreated.
Right.
But if your insulin levels are low and your blood sugar levels are also low, you need very little insulin to control your blood sugar. And there's two important things. Number one, you need very little insulin, so you're insulin sensitive. But also under those conditions, the utilization of sugar by those patients for fuel is much, much lower because they're typically in ketosis or using fatty acids as their primary fuel source. So their demand for sugar is not that high. Now, in people with insulin resistance, the reverse happens. So they've got so much sugar going on in their bloodstream, particularly fructose, they can't use their own fat. Their fat mobilization is blocked. They're not consuming a huge amount of fat, and they've got this abundance of sugar that they're trying to deal with. And insulin is inadequate, even at very high concentrations, to adequately get the sugar from the bloodstream into the cells. So their blood sugars start going up, causes an inflammatory reaction. We can measure that, but the cells are scrambling to tolerate adequate amounts or to deal with this flood of sugar into the cells, which affects the entire Krebs cycle, the TCA cycle, which is where you metabolize sugar. They're not turning it to glycogen. They're not turning it into sugar. And if you eat some protein with that, now you've also got the arginine cycle going on. Right. So all of those are huge hits for uric acid production. We see urea production, we see creatinine production, and we see uric acid production, the nitrogen waste products, which is really what we're talking about. So under the conditions of prediabetes, you've got the pro-inflammatory vascular system. You've got intracellularly every cell being flooded with sugar, particularly fructose that has gone beyond the liver. So the venous fructose levels are higher. Remember, your veins are on the other side of the liver. It goes gut to liver to arteries to tissues to veins. So by the time you're measuring fructose levels in the veins, it should be at its super lowest. And if it's measurable, that's a real problem. But every cell is now exposed to these high levels of fructose. And even though someone's insulin resistant, that fructose is getting to the cell very easily by the insulin, non-requiring insulin GLUT pathways. GLUT is the insulin receptor. So there's some require insulin, some do not. And fructose uses an insulin-independent pathway to get into the cells. So you're seeing these high levels of fructose in these cells, and then you, on top of that, add some seafood or add some red wine or whatever it is, and you get that response. And that's where your flare is coming from. Does that make sense?
Well, that makes sense. And I'm thinking about my own journey here because, by your definition, I reversed prediabetes a long time ago. My insulin's really low along with the C-peptide. But then I wonder about, and I'm thinking in the background all the time about the gout attack that I had before the prediabetes diagnosis, right? But coming back to what I'm trying to say, when you're talking to other experts about this, right? They bring in not only the A1C and the fasting glucose issue around reversing diabetes, but also the lipid panel and inflammation markers and all of that stuff, with the argument that all of these different pieces need to be a certain way before
they are secondary to the reversal of insulin resistance. In other words, your lipids are high LDL, high total cholesterol when you're pre-diabetic, or I hate that word, when you are in insulin resistance. But
Right.
when you are insulin sensitive, your triglycerides should be very low and your HDL should be high, with paradoxically a high LDL. And that is the best anti-inflammatory lipid picture you can have in the face of low insulin levels. So that LDL is always a fly in the ointment. We're not here to discuss that right now. But low triglycerides, but typically below 75 milligrams per deciliter, high HDL, those are your anti-inflammatories. Ferritin levels come down, which is another intracellular marker of inflammation for me. Total white cell count comes down, typically below 5.0. So I don't use CRP. I don't use the traditional but very volatile inflammatory markers. There's enough in the general blood work to tell me where we are with regards to inflammation. But the insulin sensitivity is an anti-inflammatory modifier. So the paradox for someone like yourself, if you're not taking any medication like colchicine or allopurinol, is I would expect at first for your uric acid levels to come down, and then paradoxically, as you become insulin sensitive, for them to start to creep up, particularly if you are more carnivores, such as many of my patients are. They tend to eat a lot more meat product when they're not eating carbohydrates. And I've got a large population of carbohydrate abstinent patients, which basically means they're pure carnivore.
Yeah, so let's come back to what you were saying before, because here's my thoughts on it. I was looking at this from the point of view of trying to what are the target organs? We have the liver, we have the kidney, we have the joint where the gout flare can happen. Okay, so someone goes on the ketogenic diet, they get reversed in terms of the diabetic thing. So you are able to say, okay, I'm not insulin resistant anymore. I'm insulin sensitive now. But my uric acid is running high, right? And remember,
you don't have gout. That's the point I was making earlier on. Gout is a symptom. It's an inflammatory condition of the joints.
Yeah.
This cohort of I'm looking at a cohort of 100 carnivore veterans who all corrected insulin resistance. Okay, so that by definition, these folks are all insulin sensitive. They're early on in the first year or so that they did this, they got their on average, their uric acid to drop down to 5.9. Now, ideally, I want it below 5, but certainly below 5 to 5.5. They got theirs down to 5.9, not completely normal. And then slowly over time, as they ate a low carbohydrate, ultra low carbohydrate, high protein, high fat diet, their uric acid levels climbed up to 7.8.
Yeah.
And then when we removed the fat from their diet, it came back down to 5.9. And we can explore that a little bit more. But here's the key thing. They don't get gout. Even though they've got hyperuricemia, they don't get gout because they don't have the inflammation that is required to make high levels of uric acid symptomatic. Now, I don't know what their joint uric acid levels are, but their serum uric acid levels, we test all the time. We test BUN, we test creatinine, and we test uric acid because those are the nitrogen breakdown products that are important for carnivores to know. Because remember, just for those that don't know, sugar and fat are made of carbon, hydrogen, and oxygen. Protein is made of carbon, hydrogen, oxygen, and nitrogen.
Yeah.
And it's that nitrogen balance that's so important to understand as potentially a driver of this as well. So it's not just purines and pyrimides that come from cells, and typically protein comes from cells. We also have to look at the nitrogen balance. So I look at uric acid not just in terms of purines and pyrimidines, but also in terms of protein.
Yeah, well, that's a really interesting thing because I did not have any gout flares after I went onto the ketogenic diet, and now I've been doing this for 3 years. I didn't until after reading Johnson's work, I went on allopurinol because my average uric acid was between 7 and 8, just like you just described right now. And
why are you concerned? You see, that's the question that we're asking is, number one, why are we concerned about that, or should we be concerned about that? And number two is, how do you treat that?
yes, that's my question, because
Right.
I did have a flare. It's a minimum one because I am seriously ketogenic, right? I mean, the pain was like a 1 or a 2 compared to a 10, right? But that never happened to me until I went on allopurinol. So that is my central question to you. What do you do? Because I have a lot of people that are reaching out to me about this now, right? Because this is what I do.
Right. So here's another word I absolutely hate, is the word keto, because it means nothing.
Okay.
It's such a broad spectrum of definitions to it. Describe to me what you eat. What do you
Yes,
drink?
I know. I've listened to a bunch of your videos, and I was going to get to this point about the pendulum aspect that you talk about. So what do I eat? My fat is around 75 to 80%. And then I have a large amount of protein in there, and my carbs have been under 50 grams total carbs per day since I started this business. And like,
those 50 grams of carbs, what are they made up of?
Just what's in the vegetables. I don't.
So that's totally irrelevant, because that all gets pooped out. Extremely few vegetables. When you take especially leafy vegetables, 100% of them basically are carbohydrates. Cellulose is a carbohydrate, but the human intestine cannot absorb that. That's why I'm so opposed to the measurables, because 50 grams of carbohydrates seems like a huge amount, but you're pooping all that out, or the majority of that's being pooped out.
I'm only getting it in from like broccoli or cauliflower.
It's going in your mouth. It's not going into your bloodstream. And one of the critical things for me is what is entering your bloodstream, because remember, your intestinal tract is outside your body.
Yeah.
Think about that. So when you put broccoli in your mouth, you say, "Oh, I've eaten broccoli." No, you haven't. No, you haven't. You've put it in your mouth, and it may run straight through, or somewhere in the small intestine, some of that may be absorbed. But it's the absorbable stuff that's important, not what goes in your mouth. And that's what dietitians often can't quite understand. They measure all these things in a laboratory of what's contained in stuff, but it's irrelevant if it doesn't get absorbed. So because that 50-gram carbohydrates is high, but we don't, in our practice, we don't measure carbohydrates in vegetables because they are not relevant in terms of disease progression.
Yeah, I basically don't worry about the carbs because I'm not taking them in any other way except.
What is the problematic number? Well, let me ask you this question. How long have you been doing this for?
3 years.
Right. And so there's a combination of two things. What is the exclusive purpose of a low carbohydrate, high fat diet, which is basically what you're on? What is the exclusive purpose of that?
Well, my exclusive purpose was to reverse my prediabetes.
Correct. And have you done that? Are you insulin sensitive?
Yes.
Right. So the purpose of a low carbohydrate, high fat diet has been served. You've achieved that. When you continue with that, you then become glucose spared, insulin depressed or insulin suppressed, protein resistant. And those three things are measurable in our high fat. Dave Feldman and I have been talking quite a bit about this in our high fat, especially carnivore or ketogenic folks, where they've swung that pendulum from insulin resistance to insulin sensitive, and it's measurable on their insulin numbers. But now they're still eating huge amounts of fat. Well, if you're eating so much fat that your body really has very little need for sugar, then that sugar is going to be a problem to the human body. Now, where are you getting your sugar from? Because you're not eating it. It's not being absorbed. Where is your blood sugar coming from?
Well, it's being produced by gluconeogenesis.
From which product?
Proteins.
Right. And what is the one molecule or element from protein that doesn't occur in fat and sugar? Nitrogen.
Right.
And your BUNs, we see the BUNs going up. We see creatinine going up. Creatinine is a function to a certain extent of kidney function. And then we also see uric acid going up. So we see all three. I haven't measured ammonia levels, but we see all three nitrogen products going up. So, everyone thinks of uric acid as being a fructose byproduct and a purine pyrimidine breakdown product. but I also believe that there's a high nitrogen component in that. Zoe Harkin will tell you that most people on any diet, the one constant number is their protein consumption. But my prediction is your protein consumption is not only higher than it probably should be, but your protein utilization for energy and for as a protein substrate, as a nutrient, is very, very low. And therein lies the problem. Does that make sense?
Well, yeah, I know that my protein is high because in the last 6 months I pushed it up because I'm very athletic and I was working out.
Well, the problem is that everyone thinks they're a little bit light on protein, no matter how athletic you are. However, the human body has a very specific threshold above which it cannot use amino acids as amino acids. And the one thing that the human body does not have, it's got to store for sugar as glycogen, it's got to store for fat as fat, but it has zero storage capacity for protein, for amino acids. So it has to convert them to sugar and then to fat. But if your insulin is super low, now your blood sugars are starting to elevate. So we're seeing a rise in blood sugar, we're seeing a rise in A1C, not to diabetic levels, and then we're seeing a rise in BUN, blood urea nitrogen, and we're seeing a rise in uric acid level in these carnivore veterans that are still very high fat. We also see an elevated LDL. And how do I know this? Because the correction for this is to lower their fat consumption cyclically. So we use a low carbohydrate, high protein diet, or the same protein, but we cut out the fat, a protein sparing or fat removal diet. Guys like Paul Saladino talk about it, Maria Emmerich. I'm not certain I like their approaches completely, but what they're doing is they're triggering an insulin response. And the problem with you right now is you're so fat adapted, you don't have an adequate insulin response. Does that make sense?
Yeah, no, well, this is really interesting actually, because I know that Scott's going to ask you when he gets a chance here, he's going to ask you then what is that, and I guess that's what I'm asking you as well, is like, okay, so I reversed the diabetic aspect of this. I was a gout sufferer and my uric acid was running high. I've got all these people asking me, including myself, asking myself, is this high uric acid acceptable, right? This value.
Right, and that's the big question. I don't have evidence of this, but I'm very afraid of it. I'm afraid of it for a variety of different reasons that may not necessarily purely be kidney and joint. I'm afraid of it in the small blood vessels and in the skin. So, but at the same time, that the thing that's causing the uric acid to go up is also causing other numbers to go off. So it's not just one number that's bad, or bad by normal standards.
I understand that one number in this business is never like, no, I get that. We're talking about a system here. So,
and we see creatinines going up. I see creatinines in the same cohort. My creatinines are 1.01, which is very concerning for me. Their BUN is at 26, which is high. So we're seeing all their nitrogen parameters are elevated, and that's a concern for me. And that's because they become protein resistant. So the solution is to lower fat consumption in a cyclical way, to stay fat adapted, but to lower fat consumption in a cyclical way. And if you lower fat consumption, you create a glucose, an insulin demand. Because really the problem here is you're not even releasing insulin at meal times.
Okay.
Postprandial insulin levels in this cohort are so low that they're almost in the type 1 diabetic range. Now, so when I looked at this, I didn't understand this data. I didn't understand this information. But fortunately, I had a cohort of 7 patients who are type 1 diabetics, not a big N, but seven type 1s, all on insulin injections, either by pump or by shot. And all of them, these 7 people are all carnivores. Because the problem with type 1s is not the type 1, it's the type 2 component. They develop insulin resistance when they're told to eat a lot of carbohydrates. When those same type 1s correct themselves and get off the carbohydrates and go on a low carbohydrate, high fat diet, their A1Cs come way down. So they've done exactly what my veteran carnivores have done. A1Cs come down, the insulin utilization comes down, but their uric acid average 4.5. 4.5. Why? What's the only difference between this cohort, my 7 type 1s, and my carnivore veterans?
Well, because the protein is being used as a
They
nutrient.
can't make insulin.
Oh,
So
okay.
Is that the answer?
that's the answer. You're not making insulin, so your blood sugars go up a little bit and you get all flummoxed about it, but you can't control it because you're not giving yourself insulin. These type 1s are aggressively managing their blood sugars to keep them in the 80s, where normal blood sugars are at 83 to 85. And they're aggressively managing themselves with insulin injections. So they're doing what you're not doing. They're actually giving themselves insulin, small amounts, but adequate insulin to manage their blood sugar. So they're remaining in a net positive nitrogen balance. You are in a net negative nitrogen balance. And that's part of the issue. Does that make sense? So the only difference between these guys, I've got one patient here of that cohort of 7. I just saw him last week. Hemoglobin A1C of 4.5 for a type 1 diabetic. And he's been a type 1 diabetic. How old is he now? He's 60 years old. He's been a type 1 since he was 6 years old. Think about that. Highest A1Cs were over 12 or 13.
Wow.
So, and that's because he was managed the standard way. But his uric acid is 4.5. Okay, blood sugar is 80. Tightly managed because he's controlling his blood sugar, whereas my carnivore veterans are not doing that. And really what it's about is insulin. And insulin affects the uric acid cycle, I believe. Again, I don't have the data. I've got the clinical evidence of this if you compare these two groups. Now, the final piece is when I get my carnivore veterans to cycle a low protein diet, a low fat diet, their uric acids are coming from 7.8 down to 5.9, creatinines from 1.01 to 0.80, BUN from 26 to 22. So they're correcting all of these numbers by getting rid of the fat, by being less fat adapted.
So what does this cycle look like on a 7-day period?
Well, it depends on how you do it. There's a lot of variability, and some people can and some people can't tolerate. In my own life, what I do is I'll eat a high protein diet for 3 days and my regular high fat diet, which doesn't really vary. I'm 95% carnivore, but the high fat for 3 days and then 3 or 4 days, and then the high protein for 3 days. The problem is that you've got to eat more, or you should be eating more frequently on the higher protein diet, and you get really, really hungry. You get very, very hungry because you don't have the adequate fat to suppress appetite. But some people do it 1 day on, 1 day off. Some people do it between meals. There's a variability there, but you want to cut down the amount of fat you eat. The way I explain it to people is if you're a pure carnivore, human carnivore in America, what is different about what you eat and what a leopard in Africa eats? You know? Raw cooked. But the difference is this, that we eat a lot of cows, we eat a lot of very, very fat meat. If you look at a leopard or any of the mammalian carnivores, they eat very, very, very lean protein. Gazelle has almost no fat in its muscles. So what the leopard will do is eat the intestines and eat the organs.
Right.
Organ meat does increase uric acid levels, but we'll eat the organs first, and then we'll eat the little bit of fat in the chest and the belly. And then for the rest, it will go back and go back and go back and eat the red meat, which is pure red meat. Think deer meat in America. It's very, very low in fat relative to a ribeye steak. So these animals are having periods of time when they eat a higher fat amount of food when they first kill the animal. And the reason I use leopard, not lion, is because lions are pack animals, leopards are loners. So they get to eat their choice of the food. But for the most part, what they're getting in for their subsequent meals, and none of them finish that gazelle all at once, is the lean protein. And that's the big difference. So when we cycle our patients, even our carnivore veterans, that cycling helps them to lower their LDL, lower their uric acid, lower their creatinine, lower their BUN. And yet their insulins come up a little bit, but really not into any abnormal territory. Does that make sense?
Yeah, it does.
So I think the quarterback hormone here of all of this gout and uric acid and all of those issues, the quarterback hormone is insulin and insulin resistance. So it's insulin with the insulin receptor. and then the trigger being fructose, which functions independent of insulin resistance, but is a byproduct of insulin resistance because very few people eat fructose or drink fructose purely as fructose. We usually get it glucose and fructose as the combination, and it's the glucose that is insulin dependent. Does that make sense?
Yeah.
So it's our standard American diet that is causing this. Now, if there are branches that will say, oh, it's the polyunsaturated fatty acids, that's not true. We know absolutely that that's not true. Polyunsaturated fatty acids potentially, especially if your 3 and 6 omega fatty acid ratio is in the 30 plus to 1 for the 6s, do trigger inflammation. But even in the absence of that, you're still getting the same problem with prediabetes or insulin resistance. So it's not don't allow this discussion to be contaminated very heavily by the polyunsaturated fatty acid group.
I'm not. But here's my
It'll happen.
Okay. So here's the question I have for you, and I get this from a lot of the people that interact with me on my YouTube channel. This comes up all the time. So I decided because my uric acid after all of this time or whatever had settled out at about 7 mg per deciliter, right? Between 6 and 8, depending on the morning.
And I look, by the way, my normals are below 5.5, ideally below 5. Just for anyone listening that doesn't know what. So 7 is way up there in gout territory.
I know.
I'm worried about above 6.7, 6.8. So I start.
Yeah, and the discussion all the time, and I know that we have some that are with us live right now. There's a guy in our chat, Peter, is already asking about this. But so, and they're asking, do you go on allopurinol or do you wait? So I went on it, right? And my uric acid right now is 4.5.
Makes the numbers look beautiful, doesn't it?
That number itself looks beautiful. The question is whether I should go off of it and come back into, and try some of the stuff that you're talking about and see what happens. I mean, this is a really big question. It's not just mine. It's the people I'm coaching too.
I would use the same argument with you is that statins reduce your LDL and your cholesterol levels, but they do not reduce your risk of a heart attack or a stroke.
Right.
So let's back out of that for 1 second, because there is a little bit of a paradox. And the paradox is this, is that a lot of people who have previously had gout, who start a ketogenic diet, and a part of that, the purpose of a ketogenic diet is to reverse gout, because they've heard everybody like myself say you can get rid of gout through a ketogenic diet. And then they have all these flares in the first few months after they go ketogenic. Well, the reason for that is because they're not insulin sensitive yet. So please understand that in the first 3 to 6 months, if you've had gout, you're likely to have a gout flare or two during that time. So if you've been on allopurinol or you have colchicine at home, keep it handy, stay on it for at least the first 6 months of a ketogenic diet before you really reverse it, and check your insulin levels before you decide to slowly withdraw your allopurinol, because gout flares early on are very common. And they're common not only because of the change in the diet, but still being insulin resistant. There's an addition, because most people on a ketogenic diet lose a lot of weight. Well, the weight is not just fat weight. There's also a lean muscle mass weight loss that goes along with that. There's a degree of autophagy. There's a greater degree of intermittent fasting. So you're not only losing fat from your fat cells, which is really not cellular breakdown, you've also got a more robust, greater turnover of your lean muscle mass that contributes to that gout early on. But once you get out to about 6 months, 8 months, and we're measurably insulin sensitive, or when your diabetes starts to go away, that's when you can probably wean off your allopurinol. The problem then is, and this is what we're trying to preach to the world a little bit more, and it's just something we're starting to see because of our patient population, is that pendulum swing the other way. And I don't know in my patient cohort whether that correlates with an increased risk of gout or kidney stones. That's the question. I don't know. However,
when the pendulum starts to come back.
Well, we see the uric acid come down, way down, below 5.5.
That never happened with me.
Right. And I know it didn't happen with you. And then what we then see, though, is that the uptick, the rise. And then the subsequent drop happens when you become, when you produce insulin in a diurnal pattern. In other words, when you're producing insulin at mealtimes, but you're glucagon dominant. So what you want to do is be insulin dominant during and after a meal, and then be glucagon dominant between.
Yes.
So that's when we see that cycle. So where you are right now, my advice to you, and it's your choice whether you stay on the allopurinol or not. The numbers look pretty, but I don't know what's happening inside of you. So what I would suggest you do is to start cycling your protein and then slowly wean your allopurinol so that the numbers are below the 5.5 to 6 range. 6 is a little high, but so that you keep your uric acid levels good off the allopurinol as you wean it. Don't stop it directly, and have some colchicine available in case you get a flare. But you can also stay on the allopurinol. No, that same thing with the drug I use most very commonly is metformin, and I don't stop metformin until very deep into the diabetes resolution process. Same principle. So I know you're eager to come off your medication, but what you've really got to look at is what is the damage potentially or real that elevated uric acid can do. And I don't know. I do not have an answer for you because I don't know whether the elevated numbers in someone eating the way you are correlates with disease.
Well, and here's the thing, right? And this is, I just talked with Dr. Johnson earlier today, right? You have uric acid is like Dr. Jekyll and Mr. Hyde, right? When it's at an intracellular level, it's operating differently depending on its concentration than it is extracellularly, right? And so the issue so we're talking about, we're in two places as we have this discussion, and we're moving from one compartment into another, right? So the issue of like my high uric acid, like when I measure it right now, that's an extracellular phenomenon. So the question is that okay or not if it's elevated?
Well, really, the question is, where did that come from? And it probably came from the liver. It comes from other tissues as well, but by far the commonest on the people on the standard American diet, their high uric acid levels are released by the liver.
Right.
Greatest fructose glucose turnover is, that's where purines and pyrimidines go home to rest. So that is production. The question about intracellular uric acid is, did it get into the cell from outside, or is it being produced inside of the cell? In other words, is it a byproduct of cellular metabolism, or is it an entrant into the cell? And I don't know the answer to that. Someone like Dr. Johnson may know that, but I just don't know the answer to that.
Well, I think at least from the literature that I've been living in now for a few months, you need the expression of JNK1. And I don't think that can happen from the outside. I think that you need uric acid inside, being expressed right there inside a hepatocyte in order to get JNK1 expressed and to initiate that cascade that can then correlate or associate with the formation of an inflammasome, right?
I'm not talking about the liver. Because the liver doesn't get very inflamed. It's really more and the hepatocytes are a different story. That's a fat story. Don't take that statement out of context. I'm talking about non-hepatic cellular cells. Regular cells, are they net producers of uric acid as well? We don't know. I don't know.
What about the proximal tubules of the kidney?
Right, so the obvious ones are the kidney and the liver. We know are chondrocytes net producers of oxalic acid?
I don't know.
Right, and I don't know either. And those are important questions. And under pathologic and normal conditions, I don't know the answer to that. Because the question is that oxalic acid in the joints, is that a secretory oxalic acid from the bloodstream, from the fluids, from the blood, or is it a production problem from chondrocytes and other cells that line the joint space? So those are all. You see, I just don't know enough. I'm not a gout specialist. I see a lot of it. I manage it as a byproduct of what I do. But those are important questions.
Oh, absolutely. And what I tried to do in developing that hypothesis was to see if I could at least show a connection to the chondrocytes in the literature. Could you find it? Could you find the production of JNK1, for example, in the chondrocyte? And if anything, which of those inflammatory proteins that gets produced in the liver, and actually I've discovered in the kidney or in the chondrocyte, do they have any connection with the inflammatory cascade? I mean, and because I wanted to see if we could show being at the scene of the crime. You know what I mean? It's an association, obviously. So, but anyway, coming back to this, so no one really knows whether what the level of extracellular uric acid is doing, either good or bad.
Correct. And that's the problem. We don't know if that is causing joint crystallization in these folks, because if they're asymptomatic, I don't know of anyone that's sticking needles into these people's knees and big toes. I also don't know who's monitoring their urine. I don't test routinely for uric acid, uricasuria. I test blood uric acid levels. So
Right.
we don't look at that. Those are all plausible things to look at, but that's, my primary role is not gout. But the question really that we're discussing in detail is, should we be concerned about higher uric acid levels in people who are not consuming glucose, who are insulin sensitive? And I don't know the answer to that. Intuitively, I'm concerned enough, but that may not necessarily be correct.
I'm just writing that down. Yeah, because no, these are questions that I've had too. I mean, part of it is that we don't normally measure uric acid. I think it's
I do it routinely in every one of my patients.
But you do.
Yeah.
But
so the point is, I've got tens of thousands of blood work tests where we've looked at uric acid. I measure it as a routine in all my patients because I want to know what's happening to nitrogen in them, not just the purines and pyrimidines. I want to know what's happening to nitrogen.
Well, I have a question for you. Can you be my doctor?
Yeah, I'm not a family doctor. Certainly, we can test. If you have a consult with us, we can do the blood work to look at this. But I do not want to be a family doctor.
Well, I don't need a family doctor. I need a diabetes, uric acid, gout.
That's what we do all the time. 60% of my patients come in with flagrant type 2 diabetes, A1C of 6.5. So, and then almost all of them have insulin resistance somewhere along the line, have either recovered from it or currently have it. So that's the wheelhouse that we play in. Some of them are heavier, some of them are not, but that's the group that I play with. So I've got this cohort of patients that I've followed for years and years. I just looked at a guy now who I posted his picture. Richard Jakes is his name. Posted a picture of him on my Instagram account. He's been a patient of mine. He weighed. We'll just look at the pictures. And he's lost several hundred pounds and kept it off for 16 years. But I got blood work that goes back 16 years on this guy. And we do blood work twice a year, every year. So that tells a story.
I think I've seen him on Diet Doctor as like a case study.
He may be, but I'm not sure if he specifically has been on Diet Doctor. We've got a whole bunch. I just happened to post his picture last week, and it was pretty darn impressive about what he's done. And he's an older guy. He's in his 60s. So, well, I guess that's older than me. But this is blood work that we can trace back. I've been in this job for 22 years. So I've got history on these patients, and from adolescents, from children, all the way through to older people. And so we can pick up trends. We can see trends if you keep an open mind. And that's the benefit for me, is to look at these people sequentially and see what's happening. That's how we picked up the keto pendulum swing. I'm still not sure what to make of it, but I know what the numbers are. And we're tracking that. So
that tees up my question beautifully, Dr. Pete. I don't know.
Yes, I know. Go for it.
Yeah. So real quick, I reversed type 2 diabetes. I was diagnosed with a 10.5 A1C.
What are you now?
I'm in the 5s. I'm like a 5.4, something like that.
Good. That's fantastic. That's really, really good.
Yeah, thank you, thank you. And of course, they tried to push the drugs on me, and I said, let me give it a try with the food, and luckily I had the commitment. I actually did Virta for 6 months. I'm back on Virta now, trying to address some more challenges. But my question to you is, because you have this cohort of, I guess most of your patient base, you just said, has type 2. So, when you look at something like the weight control registry, and you look at those people and you try and see a through line, what the most successful of that population, what are they doing, right? This is what I'm trying to do, because my journey has been, when I started, I was probably around 60, 70 healthy carb. I got certain level of results. I started with Virta, dropped it down to about 30 total. Was able to drop about 35 pounds. A lot of my biomarkers relaxed, except for my blood pressure, which is still elevated. And I have about another 25 pounds to go. But I'm at the point now where I'm trying to push into a decision. Do I do carnivore? Do I stay with ketogenic? So my question to you is, if you looked at the most successful of that population, what are they doing? Are they the ones who really are hitting it out of the park? Are they carnivore? Are they 1 to 2 meals a day? Are they eating in a 16-8 window? What are, just tick off, the main things that contribute to their success? I'd love to hear that.
They've changed their perspective on their disease. You are still totally focused on what you're eating and drinking. It's irrelevant. You've already fixed that. You have never, ever considered why. Why do you eat? Why am I eating right now? Why am I doing this right now? And unless you address the why, the what becomes irrelevant. And everybody does really well when they do a ketogenic diet. Some sustain it for a decent length of time. But unless you change the behavior that caused the problem in the first place, you're never going to be completely successful. And that's now I'm changing hats here, but that's the whole carbohydrate addiction model, where calories and carbohydrates and pounds and diabetes are the focus of people that are challenged with what they're eating. Why am I eating this right now? Why am I desiring this right now? Why am I thinking about this right now? Addiction management is about breaking habits and forming new behaviors and new habits. You can't break a habit if you're still doing it, and you can't create a habit unless you're doing it every day. And it really is, where does your mind go to for emotional restitution? You may say, hey, this is a steak. I can eat as much as I want to. But that's not necessarily true. Or at times, you're eating a massive steak, and at times much less. Why? At times, you're going to eat once a day. At times, you're going to eat 3 times a day. At times, you're going to qualify a snack because it's a pork rind and it's pure keto. So the next level up for someone like yourself is to address the behavior. Ultimately, what is the only thing an alcoholic should do?
Abstain completely.
Don't drink alcohol. Nobody ever tells an alcoholic what they should drink. But everybody on the internet has brilliant advice for whatever a fat person or a diabetic person should eat. And it's irrelevant. The only thing with one caveat is no carbohydrates, the caveat being vegetables. So whether you go pure carnivore, that's fine. But to my mind, it's not what you must do or should do or have to do. If you must do something, should do something, or have to do something, you're going to fail. If you choose to do it, if you migrate there because it's easier and simpler and better for you, not necessarily for your diabetes, it's going to be sustainable. The problem is not what you've done. The problem is the sustainability and the ongoing forward movement. And that's the challenge. So whether you're keto, whether you are like, what's that woman, Daria Delirious? She's a type 1 diabetic who's a vegan. Done amazingly well. She's an orthopedic surgeon. She's a doctor. And so it really is not about what you are eating. It's about what you're not eating, which is sugar and starch. And carnivore is my way of life because it's simpler, it's easier, and I eat that way, and my dog doesn't eat leftover lettuce. So the reason I'm carnivore is not because it's healthier or better. It suits my lifestyle better. But I've got vegetarians who do amazingly well, mostly vegetarian, who'll do some eggs or some fish or some source of protein and fat. But the issue, the level up, the next level, out of the rookie status, and you've done amazingly well, is why. Why am I doing this? Because you became a diabetic, a type 2 diabetic, when you transitioned, unbeknownst to yourself, from eating primarily for the nutritional value of food to eating sugar and starch in a primary way for its drug effect, not for its nutritional value.
Absolutely.
And and that's the transition you need to make. And so whether you go pure carnivore or whether you go stay keto or whatever it may be, is less important than now behaviorally replacing carbohydrates as a source of emotion management, or eating and drinking really as a source of emotion management. Does that make sense?
It makes a lot of sense. And as you're saying that, I was just thinking, like no other eating lifestyle that I've had, if you want to call low carb a lifestyle, it's when I quieted the hunger down, like you're saying, there's this psychological hill and you have to deal with the complexities of all your feelings around food.
But Scott, let me stop you for a second. Hunger has nothing
sure.
to do with nutrition.
Excuse me?
Hunger has nothing to do with nutrition for humans. Hunger 100,000 years ago was, oh, I'm hungry. Let me grab my bow and arrow. Let me grab my digging stick. Let me go and forage for food. There was a nutritional advantage. You live your entire life within 50 yards of an abundance of food. Hunger is no longer a nutrient driving force. For the first time ever in our experience as human beings, we are facing a tsunami of food and we don't know what to do with it. It's everywhere you look. And so the battle for you is not eating, not finding stuff to eat. Does that make sense? And
I was just going to say, like, I got full where I wasn't thinking about my next meal and food all the time. So it quieted my mind so that I could start.
That may be the appetite suppression of fat. But when life throws you a curveball, where's your brain going?
Stress eating.
Of course. And it may still be purely carnivore, but now you're eating 3 hamburgers instead of 2.
Yeah.
Because that's called Rottweiler syndrome, where you stuff yourself for that bizarre pleasurable feeling, or you're adding in an extra meal when you shouldn't, or you're too tired to do your routine things. So the addiction element is a fundamentally important thing that escapes. I love Virta. I think it's fantastic. I know those guys very, very well. I know Steve Finney. I last saw him in August in San Diego at Low Carb USA. Phenomenal guy, but Steve Finney's never really had type 2 diabetes or been fat.
Mm-hmm.
And so therefore moderation is something he can practice very readily.
Mm-hmm.
You and I can't do that. And so folks like that have done biochemically very, very well, but psychologically they never needed to do well.
Mm-hmm.
And that's the challenge. So they've dealt with the prevention of a problem. You're trying to treat a problem, and it's very, very different.
So how do I deal with the psychological aspect? That's something you do in your practice. It's a whole other thing.
That's the entirety of my practice.
That's the entire. Okay.
Yeah,
I'll take a look at your site.
The foundation of what we do, and so if you want to drop a little bit of weight, the easiest thing to do there. Andreas Infeld talks a lot about this. The diet doctor guy, Paul Saladino, will talk about this. What's the other guy's name? He just joined them. I'll think of his name in a second. But what they do is they go on they drop fat. They cut fat out of their diet, cut dairy, cut fat, and you can drop some weight. I use that as a tool for people that have stalled out for a little while. So they're doing great in our program. They stall out, cut the fat for a week or two. You get hungry, so eat again when you're hungry. But doing that, or you can do the Jason Fung thing. But Jason's fasting is unsustainable, and it's kind of miserable once you've earned the badge of honor.
Even the 16-8, like just
that's not a fast. That's not eating. If you can't go 16 hours without eating, you got a problem. So no, I'm quite extended fast versus not eating.
Yeah, I don't
it's not fasting between breakfast and dinner. He's just not eating. So that's extended fast start at 36 to 42 hours. They're great early on to correct diseases, but I think long term they can be a problem.
So dial down the fat. Okay.
Dial down the fat for a little while. But I mean, those are sound bites. The more important things to understand is, why did this happen to me, and what do I need to change to stop being that person?
Yeah.
You're not a rat in a cage. In a rat in a cage, you can control everything they eat and drink. That's the the animal experiment. You decide exactly how much they're going to get access to feed.
Mm-hmm.
But we human beings are free living people, and free living people have to be seen within that context. And that's the challenge.
Interesting.
Does that make sense?
Yeah, it makes perfect sense. And I think people you hear all these people going off like it's 85%. I don't know where they get these percentages. 85% about the food, it's like, how do you put a number on what's the psychological? You seem to be saying it's a huge,
See, and I would
percentage psychological.
Right. I would tell you it's got nothing to do. Obesity and type 2 diabetes have as much to do with nutrition as alcohol has to do with hydration.
Wow.
Okay. Think about that.
Yeah.
Okay. And that's what people don't understand. That it's food I must eat. And we contaminate all of this in that way. So, that's what we do in our practice is we help people to understand the mindset of why this happened in the first place rather than treating the problem that currently exists. And that's why I think with you is I don't know whether that allopurinol is, if you weren't on allopurinol, I wouldn't start you on it.
Well, that's the question. I mean, it was a bit controversial when I started it. I had in fact, I had followers that, unsubscribed from the channel. Not to say that that's my business, but I'm trying to make an impact in this area, right? So
no, you've proven, just like anyone going on a statin, that it lowers your numbers. The question is, do those numbers need to be lowered? And certainly from my perspective, LDL, high LDL should not be lowered in the context of low triglycerides and high HDL. So I don't know whether your allopurinol should or should, at least whether your uric acid should or should not be lowered medically. I do believe, and this is a belief, I have no knowledge of this, it's not a fact, but I do believe I feel more comfortable when you nutritionally modify what you're eating and drinking to lower your uric acid level by changing what you're eating and drinking. And we have shown success, albeit relatively early, 6 months to a year now, in our cohort of patients. But whether that is of benefit to them or not, I don't know.
Well, I mean, that's the central question, I think, in a lot of this. I mean, I've spoken with Dave Feldman, too, in Clubhouse, and we just don't know, right? But so we've been going well over an hour now, so I want to be respectful of your time. But I do have this question. I mean, is it worth... I guess I had tunnel vision, number one. Just this discussion today, going into this, I was like, okay. And Scott and I have actually, in other forums, we've talked about this, right? You go down this road of the ketogenic diet, and we're being very rigid about all these different things. The question is, how do we adjust this? I don't know. You've got me thinking about the issue of the psychological thing and how you're living your life. All right. That's an important aspect here. And it didn't occur to me at the time when I was making the decision about the allopurinol, because I felt like, okay, you've been doing the ketogenic diet now almost 3 years. And unlike a lot of the people I talk to, I've been very regimented about this whole thing, measuring biomarkers every single day and all this stuff. So I knew that, that I was maintaining these percentages, even though I do it on an intuitive level. I'm not actually counting calories of food and stuff like that, of the different macronutrients. But, the question I have for you is, do you think allopurinol is dangerous? I mean, is it doing, what have I traded for here?
Right. Now, I can't answer that question because I don't know enough about it. The question is not whether it's dangerous. The question is whether it's necessary.
Right.
And that's the one where I'm not going to put one of my patients on allopurinol, even with an average uric acid of 7.8, if they do not have gout. And I still firmly know that a ketogenic diet, a well-formulated ketogenic diet, and that's why I hate the word keto, but a well-formulated non-carbohydrate diet, it's really about what you are eating, not about what you're not eating, is a therapeutic regimen that puts gout into remission. And symptomatic gout goes into remission after perhaps a few flares early on, once you correct once you become insulin sensitive. And then the question about uric acid, which is really what we're talking about here, not gout, is I don't know. Intuitively, I'm concerned about a 7.8 average, along with some of the other markers. It's not in isolation. So we're trying to find ways to correct what's been overcorrected. That's all.
Yeah. Okay. So anyway, I hope that you and I could have another discussion about a hypothesis of gout. I've invested a lot of intellectual effort into this, and I want to go down the road with it because I think I can help people with gout. That's the whole motivation with this. And you talked about the point being that we don't know, or at least this is how I'm translating things. We don't know if it's because the uric acid is arriving from some external place or if it's being produced right on site. I guess I wanted to show the on-site thing because I kind of have this intuitive feeling, a gut feeling, that whatever's going on in the joint, that the action is there actually. Because of this fact that you can find uric acid crystals in the joints of people without gout, right? So it can't just be about the crystal. Anyway, that was my thinking.
You see, I would suggest that it's not an on-site problem. I'm not knowledgeable enough to categorically say this, but my intuition is that it's more a hepatic production problem than it is an on-site production problem.
So the liver's producing the uric acid and then it circulates and gets into the joint by diffusion, and then there's an inflammatory response relative to that.
Well, there's probably joint inflammation that allows for the diffusion. Does that make sense? Because if you don't have inflammation, and my carnivore veterans don't have inflammation, they don't get symptomatic gout, despite a high uric acid level. So that's the point, is that it's a combination of inflammation plus elevated uric acid levels. And the inflammation comes from insulin resistance. And we know fructose is integral in the uric acid pathway, but it's also a pro-inflammatory marker in elevated numbers. Glucose and fructose mediate insulin resistance, and primarily glucose, which is associated with fructose. So it's not just a unifactorial thing. My suspicion is that it is a combination of all of those conditions predicated by insulin resistance. And once you correct insulin resistance, an elevated uric acid, certainly in terms of gout and kidney stones, is probably less of a concern. However, we see xanthelasma in some of our carnivore patients, which is the deposition of cholesterol in their eyes and around their eyes. So it's not as simple as saying that this fixes this. That's where my pendulum video comes from. Is if you swing that pendulum too far to the corrective side, too much of a good thing is not always a bad thing, unless you live in Texas. So the question is, what is that middle ground? And that's what we're exploring. This is not a condemnation at all about a ketogenic or a carnivore diet. I love both of those. I practice those. My 14, 15-month-old son is on one. But the question, right, because I believe it's the best diet, it's the proper human diet, as my friend Ken Berry says. However, the question is exactly what does that mean at various levels?
Right.
Healthy. Once you've restored your health, what now? And that's the question. And that's what we're just exploring right now.
Yeah, that's what Scott and I have had numerous conversations about. That's exactly what we're wondering about. And I've been thinking about this for a long time now. It's like, all right, how do I need to adjust this? And if so, what do I want to do? That's the question.
The guy's name I was thinking of is Ted Naiman, who's got the PE ratio going.
Yeah, Naiman.
So Ted and Paul and Maria. But those are all people who've never really been fat themselves. So they don't have they've never been an alcoholic. So they can drink alcohol in moderation.
What about Tro? Do you follow Tro? He was
a good friend of mine. Yeah, Tro's a good friend of mine.
He was 350 pounds. He's walking the walk. I mean.
Right. No, and Tro's done extremely well over a protracted period of time. But if you look at what Tro's the other aspects of his life that weren't present when he was fat, they've all grown tremendously. I mean, the guy runs a 6-minute mile, 6 point something, 8-minute mile. I can't run a 10-minute mile anymore. So, you know, he's doing things now that he never ever did before for emotion management. So all of those things matter. And but Tro's just a great guy. And he and I have had plenty of conversations on the addiction model, and he understands it exactly the same. Exactly the same. Doesn't necessarily practice it the way we do, but he concurs completely. Tro, Lenski, all of these guys are out there in terms of recognizing this. The question is how do you transfer this into a therapeutic model, and that I think is what we've done pretty well.
Yeah, that's what I want to do. Yeah.
All right, yeah, but I do have to go, guys. And but this has been, you know, it's just we're asking a lot of questions, but we're not questioning what we do. We're asking a lot of questions about how to do it, but we are not questioning what we do. That's already been asked and answered many, many times over.
Right. Yeah.
All right. Thanks a lot, Dr. Cywes. Appreciate it.
Take care.
Thank you very much.
You're welcome. Good to meet you, Scott. Bye-bye.
Absolutely. You too.
Bye.
Bye.